California is now the nation's social distancing bellwether. The Bay Area was the first region in the country to impose sheltering in place. Then it was followed by the entire state. California, the first statewide order covering 40 million residents. As of now, over 5,200 cases in California and sadly 118 deaths. Those numbers, though, are well below what we see in New York. The big question is, at what rate will the California numbers climb in the days and weeks ahead? Joining me now, Dr. Jonathan Gelber, emergency room physician in Oakland, California. Jonathan, it's good to see you. It's been too long, and I don't like the circumstances. Let's go through your experience. Your COVID-19 caseload has been steady, but not yet overwhelming. You believe that time has helped your hospital learn some valuable lessons. Let's start with patient care. We'll get to protecting the workers later, but on patient care, what have you learned in your drills and in studying Italy, South Korea, even New York?
Well, I think especially studying New York has been especially valuable. That, like Elmhurst Hospital in Queens, the hospital that I work at, Highland Hospital in Oakland, is a safety net hospital. We do care predominantly for vulnerable patients, of people who have unstable housing or are frankly homeless, and that has helped us tremendously plan for when we work to plan discharges, when we tell people things like shelter in place, to make sure that people have a shelter to shelter in place in, meaning that it's a lot easier to tell somebody like me to go hang out at home for 2 weeks and get food delivered. It's a little harder when the patient is a 55-year-old gentleman who lives in a tent encampment under the 45th Street bypass, and with 15 other people. So we've learned how to plan for that and see our problems ahead of time before they arise. That's saying, hey, how do we keep the curve flat? How do we keep the patients like this from infecting other patients at shelters, at homeless encampments, as well as the general patient population? And how do we keep the people in the emergency room safe from infecting each other in the lobby, from infecting loved ones who are coming to visit? And we've learned a tremendous amount from our colleagues in New York, in Italy, in China, Korea, all over the globe.
Right, and I want to follow up on that in terms of protecting the patients and protecting yourselves and protecting all the medical workers and all the people in the hospital. You're at a huge risk. The latest numbers from Italy are just stunning. 8,000 medical workers have contracted the virus. 61 have died. You tell me that you've studied how they were doing things and you're making some big changes because of them that you think will help protect you and your colleagues. Tell me about those.
Absolutely. First of all, we found that simple things that just done to protect patients protect us. That as simple as when somebody comes in the ER, into the ER lobby, they get a mask. It sounds super simple, but if you assume that everybody has some potential for having COVID-19 and put a mask, little things like that can help reduce spread. But in terms of what we're doing to keep ourselves safe, in addition to PPE and personal protective equipment, we're making huge changes in the way that we organize our emergency department and the way that we approach somebody who may need life support for treatment of their COVID-19. For example, that when somebody needs a breathing tube put in, it used to be a bit of a all hands on deck scenario. Medical students, residents, attendings, respiratory therapists, everybody coming in to lend a hand. We're limiting the number of people in the room. We found that things like putting in a breathing tube is an extremely high-risk procedure for healthcare providers. So we're limiting the number of people in the room. We're using video-assisted technology as much as possible to not physically look into the airway and be exposed to viral particles. And we're making sure that people who are performing these procedures are wearing PAPRs or powered air purifying personal respirators to make sure that we limit our exposure as healthcare providers. These are things that are done in China and Italy and are being done now in the U.S.
I want to ask you one other question about non-COVID patients, because you wrote to me about the stress of treating a large homeless community in your area. And so some guy comes in off the street who has a heart condition. You treat that person and they're leaving the hospital. Your fear is that you're sending them back to a shelter or back out on the streets where now they're immune compromised, now they're on that risk list, and they could be exposed right away. How do you handle that?
That's a great question. It's one we're grappling with now. But like communities in New York, LA, Chicago, and San Francisco, we have a tremendous amount of social workers, county administrators, docs, and nurses working to make sure that we have housing being set up for these vulnerable populations. As you said, it doesn't do much good to either the person that I'm quarantining, that I'm sending back to a homeless shelter, or his bunkmate who's 60 years old, has heart disease, if I just return somebody who I suspect has COVID to a homeless shelter. So as of now, we're working to have between a 100 to 200 bed hotel and motel setup where we arrange transportation, food, resources, and possible transportation back to the hospital to allow people to effectively self-isolate and quarantine. So to make sure that things like self-isolation and quarantine isn't just reserved for fortunate people like me, but to make sure that our most vulnerable patients that we care for every day at hospitals like Highland and Elmhurst have access to the same level of care or have a chance to self-isolate just like I do. Because these are some of the patients that are at the highest risk of potentially dying from COVID. These are patients who are elderly, have many medical comorbidities. These are people who are not in the 0.2 to 0.3% mortality risk that somebody like me is in. These are ones that are much higher, at higher risk of really bad outcomes. We're doing what we can to keep them safe at home and in a safe living environment.
Dr. Gelber, really appreciate your insights. Keep in touch as the California challenge increases in the days and weeks ahead. Very much appreciated, and most of all, stay safe. Stay safe as you take care of people. Take a quick break. When we come back, more on the president's reaction to this, including a call with the governors right now.